Hello, everyone. Thank you for joining today's HCN's annual training webinar on UDS 2020. This session will cover information about the demographics and financial table reports. For those of you who may not know me, my name is Susie Adrigal, and I'm the manager of the system optimization team here at Health Choice Network. I've been with the Health Network for about 14 years, holding different positions here. But what remains the same is my involvement with UDS and helping our health centers obtain accurate data from the reporting tools available. So this presentation is in listen-only mode. If you wish to ask a question, please feel free to enter those questions into the question box. Towards the end of the presentation, I'll open up the line, and that will be our opportunity to ask any live questions and for us to kind of go over the questions that have been submitted so far. Also, if you look at the GoToWebinar control panel, there are 3 handouts that are available. One is the presentation slide deck, and the other 2 are documentation from Greenway, the Practice Analytics 1215 release notes, as well as the UDS User's Guide using Practice Analytics 1215. So like I said, questions are welcome. Questions that have been asked on this during the session, as well as the other 3 sessions, will be compiled in a FAQ document, and that will be provided along with the links to the recorded sessions in a separate communication. Okay, so we are ready to get started. So for today's agenda, we're going to cover Practice Analytics 1215 highlights, and it's more geared towards UDS readiness for 2020. Then we'll go over the UDS 2020, like what's new in UDS 2020, and then the approved changes for 2021. And then we'll go over the setup and workflows for the zip code table, table 3A, 3B, 4, 5, and 9D. And I'll cover just validation tips, information that I've shared, in speaking with each of you, as well as just, with the vendor on strategies for successful reporting. All right, so here's the overview of what's new for Practice Analytics 1215. So there are 3 measures that have been added to the reporting period, to the reporting year, and you'll now see them on the UDS dashboard. So they are breast cancer screening, HIV screening, depression remission at 12 months. On table 6A, a lot of updates have been added. So there are 2 lines, or actually there's 4 lines having to do with coronavirus, data collection for the diagnosis, acute respiratory illness due to coronavirus, and also testing. And I did leave out 1 item. This has to do with the diagnostic tests. Additional data collection is for human trafficking and intimate partner violence and PrEP medication, PrEP management. So corrections have been are included as well. They are on table 4, line 21A, permanent supportive housing. This actually was a new item that was part of 2019 reporting, but in the version that we are on now, PA 12, it wasn't included in time. So now it's available. And also in Intergy, a status was added in the last upgrade that we had to 12. And so now the homeless status, permanent supportive housing, is available for you to assign to your homeless patients. Another correction is with table 6A, dental services. Currently, the emergency services visits and patient counts are being reported to line 28, oral exam. So now with this upgrade, those services or the patients and visits will be counted appropriately to line 27. And the other change is with the clinical dashboard. So that dashboard entirely will be removed. And this is the dashboard that has all of the CQM reports that are available in Practice Analytics. So Greenway will be moving this dashboard to a new platform called Greenway Insights. And this is their, it's a more robust analytics system that they have developed. So there's definitely, more dashboards will be added in future releases, but the first dashboard that will be available is the clinical dashboard piece, okay? So here I just wanted to give you a preview of what the UDS dashboard will look like with the measures that are available. And you could see just the additional 3 measures that have been added here. But getting to this dashboard remains the same. Once you log into Practice Analytics using the login that is associated to the dashboard license, you just simply go up to dashboard and then you'll see this one, the UDS selection available. So for UDS 2020, the changes, I'm sure, this is, you're already aware of what the changes are. HRSA did a great job in releasing or making these changes known earlier in 2020. I think it was mid-year. So let's just quickly go over what they are. So there's continued updates to the quality of care measures that are affecting the Table 6B and 7 reports. And those are the ones that are aligned with the ECQMs for 2020 reporting. And as I mentioned earlier, 3 measures have been added: breast cancer screening, depression remission at 12 months, and HIV screening. 1 measure has been retired, and that is the asthma measure. And a change was made to the HIV linkage to care measure, where the follow-up timeline after first diagnosed is changed from 90 days to 30 days. And the additional data elements or for reporting has been added to Table 6A, having to do with PrEP, intimate partner violence, and human trafficking. And of course, the additions for COVID having to do with the diagnosis and the services rendered for testing, diagnostic testing, and antibody testing. For the approved changes for UDS 2020 is out, and it was made available in the PAL document number 2020-07, release date October 21st, 2020. So continued updates to the quality of care measures for Table 6B and 7 to continue to remain aligned with ECQM, and this is for 2021 reporting. And continued updates relating to coronavirus on starting with Table 6A with any new codes relating to testing and diagnosing. So funding, COVID-19 funding lines will be added to Table 9D and 9E. And then on Appendix E, other data elements section, a question relating to coronavirus, COVID-19 vaccination has been added. If you wish to review the PAL document, I provided the link to it here at the bottom of the slide. Okay, so now we're on to setup and workflow. So this information that I'll be sharing is specific to energy, and the workflows are applied to in energy, and of course, how that information can be seen on the Practice Analytics report. So the key UDS setup that impact the demographics and the financial report is in the UDS report maintenance, that's primary, the procedure code maintenance, poverty guideline maintenance, and practice analytics setup parameters. So here's the UDS report maintenance window. So you could see it does consist of different sections. So this is why this is known as the central location for, maintaining and viewing configurations in which the UDS report in the PA UDS dashboard uses. So here, there's going to be mapping for the UDS staff, insurance plan, race and ethnicity, settings that impact grant reporting like migrant and homeless, and then other is just pretty much a catch-all for any other areas. Okay, so let's start with the staffing page. So here, when a new provider is added to the provider maintenance table, their information will be listed here. And then a staffing category would need to be assigned to that particular provider. You can mark a provider as exclude if you do not want to count them to your UDS reporting. And when a provider, has left your organization, you don't have to go back here and make a change to, their staffing category assignment. Just leave them assigned as is. The way that the UDS report works is that it looks at records within that reporting period. And if there are no new records that have been posted or entered, then you don't have to worry. That provider who's no longer with your organization is not going to reflect, in the data for whatever reporting period you're looking for. So to easily just show which provider is missing a staffing category instead of having to scroll down, you could simply uncheck include staff with translation. And then that way you could quickly just go through and assign their staffing category. Now, when a provider is missing a staffing category, then this is a warning that you will see when you're inside of practice analytics. Now, when this warning appears, it's really important to try to get the staffing category assigned. So especially so it's great, like around this time, if you are seeing this warning and you know that the providers that are listed here, that are missing a category are providers who actually saw patients, during the reporting period, it's really important that you go in, get the UDS staffing category assigned so that way their activities will be able to contribute towards, the current year's reporting data. Now onto the insurance setup. So this is where insurance plans are mapped to the different payer categories for Table 4 and Table 9D. So it's important for you to map any plans that you've set up for Medicaid, Medicare, CHIP, special contracts, and uninsured safety net programs. Any plans that you don't have mapped will just default to private insurance. So this is really important when you're looking at the data on this table, and you see that maybe there's a high number of patients who are reporting to the private insurance line. You may want to come back and just take a look at what setups you have for like the Medicaid or the Medicare plans or the managed care plans, just to make sure that they're mapped accordingly to the correct payer categories. Another, this actually was a suggestion that I've shared with other health centers, but in the event that you want to make sure the plans that are being utilized are mapped, you can run a practice financial summary report, and that is from within energy. This is an energy canned report. So you could run that report and then to identify what plans have been utilized. And then you could cross-reference to this list here to make sure that they are mapped. And the great thing about this practice financial summary report is that you can organize it or sort it by carrier code. And then that's an easy way to know, okay, well, this plan is Medicaid or this plan is Medicare. So that way it's easy for you to kind of identify and know which ones are mapped or not mapped correctly. So for the race setup, the setup that is on this section affects Table 3B and Table 7. So it's important that if any non-standard race codes are added to energy, that they are then mapped accordingly to the UDS race codes. For the most part, the codes that come shipped with energy are appropriate. I don't see any reason to add additional codes, but in the event that some are added, then you know that it's important to remember to just map them to a UDS race code or a high number, or those patients will end up getting reported to the unknown line. For the ethnicity page, there's only like 3 UDS ethnicity codes that you would have to map any of the ethnicity codes to. It's L for Latino Hispanic, or N for non-Latino Hispanic, or U for unknown. So we actually see more additions added to the ethnicity setup. So just remember to just make sure that those codes are mapped. Pretty much like what you see here on this screen are the standard mappings. This is often what you have in your system, and you just have to make sure this is what it will look like when the codes are mapped correctly. Okay, so the next setup area is for grant reports. Now, this affects Table 3B, and of course, specific to the separate migrant and homeless grant reports that you may run. Now, the setup here is to specify the statuses that should correspond to the grant reports. So pretty much a change doesn't really need to be made. Once you pretty much have these statuses in place, then there's no need to make any further changes. So for migrant health, you want to make sure that the statuses include M for migrant, S for seasonal. For healthcare for the homeless, an update does need to be made for 2020 reporting, so that way it includes P for permanent supportive housing, since that's a new element that was added with the energy upgrade. But for the most part, you should have in place the selections of H for homeless shelter, T for transitional, D for doubling up, S for street, U for unknown, and O for other. And again, these are homeless status states. The state of homelessness, basically, is what these are. Okay, and the last section in the UDS report maintenance is other. And so, like I said, this is pretty much a catch-all. But the most important thing that you need to know are the 2 items at the bottom, because this has to do with Table 9D. So if you're doing any bad debt adjustments on your self-pay patients, then you want to make sure that the bad debt code adjustment code is specified here. And for the Table 9D insurance adjustment codes, you want to make sure that you add any adjustment codes that are used for insurance adjustments. So that way, full charges and allowances are treated as insurance instead of adding to the self-pay line. And I'm not sure if I had mentioned this earlier, but to get to the UDS report maintenance window, it's going to be in the Energy Practice Management System. You would simply click on Setup, UDS. You would click on Setup, CHC, and UDS. Then you'll be able to get to this window. Now, permissions, certain permissions to get to this setup area is required first. So make sure if you try to access this area and you're getting a warning that you don't have permission, then you know that the permission to the setup area needs to be given to your Energy login. Okay, so the next setup area is the procedure code maintenance. And this is really important because this is one of the key areas in which the UDS universe is determined. This is the first place. So of course, this setting will affect all UDS reports. Now, there's a lot of procedure codes that I'm sure you may have in your Energy system, but not everyone should be checked as UDS visit. The ones that should be checked are E&M codes, and we know which ones those are, or any codes that you may have set up that reflect or represent a face-to-face visit, that are rendered by a licensed professional, where they exercise independent judgment, and that the code is not an ancillary service. So for example, vaccine administration or blood draw procedure codes should not be marked as a UDS qualifying visit. And to get to this setup window, it would be in Energy Practice Management Setup. You would select Procedures and Profiles, and then Procedures. So the next area is the Poverty Guideline Maintenance. Now this setup impacts Table 4, the income as percent of poverty section. So every year, the federal poverty guidelines are released. So this is kind of like your reminder that to go into this window and update the guideline. So for 2021 poverty guidelines, it will be released soon, sometime during the week of January 19th through the 22nd. So in case you don't have it, I provided the link to where you can view the guidelines. And to access this setup window is, again, in Energy Practice Management, and it's under Setup. And you would instead go to the Financial section or Financial Selection, and then Poverty Guidelines. So the last setup area is within Practice Analytics. And this is a setup in which HCN, who is the administrator for your practice in Practice Analytics, has already done. So this first parameter, use supervising provider over encounter provider, that parameter is set to no. And what this parameter does is for encounters that occur, you have a choice to either use the supervising provider or to use the rendering provider. So in this case, we have selected to use the rendering, not the supervising, but the actual provider who saw the patient. So that way, when you're looking at Table 5, it's truly reflecting the staff who actually had the visit. So that is the impact that you will see with this selection, the parameter selection set to no. The next parameter has to do with table 4. So there's actually 2 that are related. The first one is UDS table 4 report poverty with pending documentation. And the other one is UDS table 4 report poverty with no documentation. And for both of these parameters, we have the selection set to % of poverty. And so what this means, when you are updating income in practice, in the practice information, you can input an income amount, but sometimes you may not have the documentation provided by the patient, or maybe they've decided, or the patient, doesn't provide the documentation. So depending on your practice's policy on collecting income information and what documentation is required, you could certainly set whether income documented is P or no. But either way, if you do enter an amount, then that these parameters will allow the table 4 report to then place that patient into the appropriate line in the % of poverty guidelines. Otherwise, that patient will just be counted to unknown. Okay, so now in this section, we're going to talk more about where the data comes from. And I'll be talking a little bit about, workflows too. So for the most part, the patient profile reports are, I think it's pretty intuitive as to, what the workflows are. So here, starting with patient zip code, there's 2 main data elements that are used. One is the patient zip code, and the other is the plan that are assigned or that they're eligible for. So this is all part of patient registration. So for the most part, a lot of the patient registration fields are set to required. I believe for most of you, zip code is. So as long as the zip code information is entered, then that patient or that zip code will appear, and then that patient will then be reported to that particular zip code line. Now, if a zip code has less than 10 patients that live in that area, then those patients will instead be reported to other. So kind of knowing where your patients live and what area is important, just in case new access points are needed. So at least now you have an idea of where your patients reside or how many patients reside in what area. So here on insurance, like I said, this is all part of your, adding, the insurance policies to your patient, and whatever their set coverage is. That's important to also include as well. One thing that I wish to add regarding when an insurance plan or when the policy is added to the patient's account, it's important to at least to key in the start date. You should be able to have that information. And if available, enter the end date, because this is data that the report will use to determine what medical insurance the patient had during their last visit. So this is good, especially if there's been changes to the insurance plans during the year and you're marking plans as inactive. So these fields that I've highlighted here in patient information impact Table 3A and Table 3B. So Table 3A is patient's age and sex assigned at birth. So therefore, the gender or the sex field here, what is entered there, as well as the date of birth, is important. And again, those are required fields. For Table 3B that look at, that report ethnicity, race, and ethnicity, as well as, other characteristics. So the race field, the ethnicity, gender identity, sexual orientation, and language is important to be filled out. Now, I believe gender identity and sexual orientation may not necessarily be required fields that I've seen, but you can make them required, but you just have to make sure if you do so, that that field has to be, that information has to be entered. As far as the race information that you input for race, now if you look in this particular screenshot, I'm showing where the race field can be entered with more than one race. So, in your patient intake form, if you have in the section, where you're asking about, what is your race? And the patient answers, they could just check off whatever race applies. Do not include on your patient intake a choice that says more than one race. That is not needed. You can just leave the standard race codes on your patient intake and have your patient self-report. And then what you could do here is just input all of those multiple races into that field. And then the patient will then report to the more than one race line automatically. So that should help as far, with the information collected during patient registration. So sexual orientation and gender identity can also be entered in the EHR system. So in these screenshots, I'm showing how you can get to it. So when you're looking at your patient's chart in the EHR system, you just have to display info, and that will display the skinny list or skinny menu. And then you would click on more to then show the patient demographics information. And then you would click on the button for edit demographics, and then you get the small window that you see here in the foreground. So here you could input gender identity and sexual orientation. But as you can see, there are other fields or other data that you can input, like their preferred name, or updating their email address, or even their primary care provider, or their contact information. And then once you hit save here, then all of this information will just sync back quickly into the practice management system. So that way, both desktops will reflect the same information. So for the percent of poverty, the information is collected here in sliding fee. So remember earlier I talked about documented income status. So depending on what is keyed in, the patient will either report to the specific poverty of guideline line or unknown. So if the documented income status is set to a yes, no, or pending, then the patient will then report to the appropriate line or level. But if the status is either unknown or refused, then the patient will then report to unknown. Now, a change was made to the period of when income is expected or income should be collected, and UDS has specified that income should be collected a year since their last visit. So this change should help as far as how the patient reports to the different percent of poverty level. So for table 4, the section that talks about the primary medical insurance. So where the report looks for this data is in the charge record. So here in this screenshot, you could see how I've circled the insurance plan, and then the procedure is really important, and the plan in which that charge is posted to. So this report doesn't look at whether the charge was, or the last visit was billed. It just wants to know, does the patient have medical insurance coverage? So if the last visit, and on the last, as of the last visit. So if the last visit was a dental visit, then it's going to then, the report will then look at the patient's policy list to determine what is their coverage, what plans have been added to their coverage, and if it's primary coverage or secondary coverage. And this is where it's important to input, the policy start date, so that way the report is able to easily identify, what medical insurance is eligible, the patient has eligible at that time of the last visit. So on table 4, line 9A, that looks at dually eligible Medicare primary, Medicaid secondary, how the report determines this is also pretty simplistic. It's just looking at the patient's policy list and in-set coverage. And if it sees that Medicare is primary and Medicaid is secondary, then that patient will then count to line 9A. So table 4 also has special population section. And here on the bottom of the sliding fee page is where special population is entered. So you could see for lines 17 to 23, that talks about the homeless status, status. This is where that information would be keyed in. Lines 14 to 16, that looks at worker status, migrant or seasonal. That's where you would input that information. And for line 25, total veterans, the field here, veterans, whether it's yes or no, would be where you would key that in. And anytime a change is made to any of the fields here in special population, input the effective date when that change was made. And this serves as a footprint of that change. Also, if you look in the history button, there's a separate tab for special population information. And there you could also see the history of when the changes were made. So this is important, especially like for the example of homeless status. If the patient was homeless at the beginning of the year, but then that status changed and they're no longer homeless, by the report will then look at the different the changes that occurred with that status, and then it will, the patient will still be counted as homeless because they were homeless in the beginning of the reporting period, but at least then it will use that history to reflect, and to count that patient accordingly. So table 5, this is the staffing and the staffing table. And for the clinical visits and patients, as well as virtual visits, this is where the information is collected from. So it's looking at your charge record. It's looking at the date of service. The report is looking at the procedure. And it's not what procedure, but that the procedure is flagged as a UDS qualifying. And it's looking at the provider, which provider was on that encounter, because it uses then the UDS staffing category of that provider to report which line the patient and visit should be counted towards. What's really important to know is that the charge record needs to have an encounter number. in order to report that information correctly onto Table 5. Now, specific to telehealth visits, only just a few data elements are needed on the charge record. So the report identifies a telehealth visit by either a modifier 95 or GT, or a place of service 02. So this is the UDS specifications, and this is not the billing specifications. So we have heard kind of some challenges here in trying to, document a telehealth visit for the purposes of billing versus what the UDS specifications are. So if you're running into challenges when you're looking at the what is being counted in the virtual, the telehealth or the virtual visits column on Table 5, please reach out and let us know, why this may not look right, or kind of like, you're wanting to get a better understanding as to how these numbers were derived, and we'll be more than happy to, look at it and just kind of go and walk through the validation process with you. So on Table 5, selected services detail addendum data. Now this section of the report is at the bottom of Table 5, below the staffing and utilization area. And so the data that's pulled for this section is actually not charge record. It is actually pulled from EHR, and it's looking at medicines to identify where visits and patients should be reported to. And it's using the same medicine-based data list that is used for Table 6A. Lines 20A through 20D are the mental health services section, and lines 18 through 19A is the substance use disorder services section. Sorry. Okay, so now we're here on the Table 9D patient-related revenue. So the next few slides will be about where to run the Table 9D report, and we'll talk more about what the different columns are. So if you run the Table 9D patient-related revenue report out of Energy, this is where where it's been available before. Greenway has made this report available in the dashboard for the past several years, but it is never, it doesn't, some of the challenges with using this report from the dashboard is that the numbers between, if you compare the two reports, are not the same. And the reason for that is that Greenway has stopped updating the Table 9D patient-related revenue report in Energy. They stopped updating it after some time. So it doesn't reflect, any of the current criteria that UDS is looking for this table. So they encourage or recommend actually that, centers run the report from the dashboard. And it's actually better because when you do run this report, it takes less time to generate. Before Energy, it may take hours to finish compiling. So at least it's faster. You do also can get detailed information. So on the next slide, this is what the report will look like. So you could see it has the different columns that Table 9D have. Just columns C1 to C4 are not calculated by the UDS dashboard report, and of course are not displayed on this report output. Let's go ahead and just let's go through what each of the columns represent. So the first column, A, full charges, and that reports the total charges for each payer category. Okay, so charges are included if they are billed to and covered, at least in part, by the responsible party, even if some or all of the charges were written off due to contractual allowances, sliding discounts, or bad debt. So column A adds all of the charges made against that payer, the payer categories, during the reporting period for patients who qualified for Table 9D. So in order to be counted to column A charge must have been made during the reporting period, as indicated by the date of service that occurred in that reporting period to an insurance plan assigned to a UDS payer category for services that were given to the qualifying patient. So any charges that are posted without an attached insurance plan will report to line 13 self-pay. Any payment activities or voids will use Energy's journal dates. Now, column B shows all of the total payments that were made from each payer during the reporting period. So in Energy, payments must have been posted to a journal date during the reporting period to be included. So column D, allowances, reports adjustment amounts for each qualifying patient totaled by the payer category. So only adjustments that are posted into an Energy journal date that occurred during the reporting period will be included. So column E shows the total number of adjustments marked as sliding fee adjustments for each qualifying patient. So this includes adjustments with an adjustment code that's been configured as a sliding fee adjustment, and that's done in the sliding fee schedule setup area. And any adjustments credited to an insurance plan that has been mapped to the ICP category, and that's in the insurance page of the UDS report maintenance. Column E only reports for self-pay category line. So that's why you see pretty much in column E, lines 1 through 12 are blank, because it's only for line 13. And only sliding fee adjustments posted into an Energy journal date that occurred during the reporting period will be included. So this can include slide adjustments for charges that were serviced outside of the reporting period. If the service was provided prior to the reporting period, but the charge is voided during the reporting period, then any sliding fee adjustments will be subtracted in order to reconcile slides across the reporting years. And last, column F, bad debt write-off, shows only the total amount of bad debt for the self-pay category. Adjustments will be included in column F if they use an adjustment code identified as bad debt code on the other page of the UDS report maintenance window. So these adjustments must have been posted into a journal date during the reporting period in order to be included. So here, this is the insurance mapping that you would set up in the insurance report maintenance on the insurance page. So this screenshot shows which payer category corresponds to which line for Table 9D. Okay, so on to tips for successful reporting. So first, helpful tip that I find is, and I promote this, is to use the details section or details information that the UDS reports provide you from the dashboard. So for the like the demographic tables, like the zip code or table 3A, 3B, table 4, you have available a patients list button and a visits list button. So the patient's details button gives you the zip code, date of birth, sex, and UDS race and ethnicity information. And the visits details button gives you the encounter provider code for that visit, what qualifying UDS code occurred, the plan, and the report plan. So the actual plan that the visit code was associated to and how that plan is mapped to. So for the table, table 3B and table 4 reports, you'll see supporting data button. So in this list, if you're looking on table 3B, the supporting data information will display the patient's language, sexual orientation, and gender identity records. On table 4, homeless status, worker status, veteran status, and public housing status will be displayed. So here is a list of just, I would say, like, these are considered cross-table considerations, and I find that this is just good information to know, especially when you're using the PA dashboard report to populate, the UDS submission in the EHB. So first, you want to make sure when you run your UDS summary, that would be the first thing that you would do, is generate the scorecard, the UDS scorecard, and then you would then make sure that the total number of patients in the UDS universe is the same across the zip code table on 3A, 3B, and 4. If there are variances between these numbers, then you have to determine, what is causing this variance. It could be maybe a record that wasn't updated correctly. Like there was an example, a scenario that I researched where on table 3B, something wasn't correct with the race code in one of the patients, and it wasn't reflecting correctly on table 3B. So we were able to identify that particular patient record, and then we had to just refresh that information. So it's important to make sure that at least, the UDS universe on these 4 tables are the same, because that the information on those reports reflect unduplicated patient count. On table 3B, it's important to, when you're looking at table 3B and you see a high number of patients being reported to unknowns, you want to see what is the patient's race and ethnicity, code assignment. There may be codes that you might have set up in your system that are unmapped. So of course that's the first thing that you would look at. You would then go to the UDS report maintenance window and just determine what's there. And then on table 4, and I think I may have mentioned this before, when you're looking at that report and you see a high number of patients that report to private insurance, now of course this might be valid, but if you know that you don't have a lot of patients who have private insurance, or you may have a large uninsured patient population, and you expect the number to be higher, then you want to definitely make sure that you have your plans mapped correctly. And for table 5, you want to just look to see, which staffing lines have numbers. And if you see one that might be underreporting, then you want to make sure that provider staff code is assigned to the correct UDS staffing category. So here, we're actually nearing the end of this presentation, and then we will have some time to answer any questions or discuss any live questions that you may have. So what I wanted to provide you with is a list of resources. And then these are actually ones that I personally use when I'm validating your UDS data. So of course, I have bookmarked the link to the PA UDS help. Now, you know that this is this help you can access from within the practice analytics, but you can save it to your browser and you could access it outside. And this is helpful when you're just looking at data from Excel, and then you're able to understand like, why is this information here, or what are the criteria. The next resources that I use is what is available on the UDS resource page. There's a lot of helpful information that HRSA has made available there, including any trainings that have been done. I think in 2020 there might have been like 6 or 7 trainings that UDS did, and they are definitely very helpful, especially if you're new to UDS reporting and kind of like reading the specifications and the nuances is challenging. So at least you have the trainings available, the recorded trainings, to help guide you. And for those who validate, more of the clinical data, then having the ECQI Resource Center as well as USHIC and VSAC linked is very helpful. For the clinical quality measures report, this is pretty much the source of truth. On the ECQI resource page, this is where all of the criterias are specified. The actual algorithm and everything, it's all there. It's the logic is given to you, so there's no mystery as to how is this coded. That information is there, and that is the information that Greenway uses to code their UDS report. And the value sets are also available on VSAC, and you could easily link to it from the ECQI resource page to VSAC. And that way you could see what are the qualifying data elements that the reports look at. So it's information has become very transparent. So now we have some time. It's 2:58, and this webinar is over at 3:30. So we have time to answer some questions, and I do see some that have been asked during the presentation. So I have unmuted the line. So if you wish to ask any live questions, you may do so, but you have to unmute yourself first. Let me first just go over the questions that have been asked. Okay, so the first question was how to access the UDS report maintenance window. I believe I provided the instructions before, but just in case, I'll repeat them. The UDS report maintenance window is accessed from within Energy Practice Management, and it's going to be under Setup, CHC, and then you would select UDS. The telehealth codes. What drives telehealth codes to be counted on the dashboard? So for UDS purposes, it is simple. I mean, they're only looking at the modifier 95 or GT and the POS 02. So that's all that Greenway has coded in that portion of the report. So another question is, what happens with dental telehealth visit that doesn't utilize a modifier but a procedure code D9995? That is a great question. So unfortunately, if you're looking at the Practice Analytics UDS dashboard report, table 5, then you're not going to see that telehealth dental visit report there, because the report itself is only coded to look at those elements that I mentioned before. I think for this, I have to check with UDS to see if they will open up or expand on the requirements for identifying a telehealth dental visit. When they released their specifications for telehealth I think and it's been some time because the telehealth requirement or identifying telehealth was added to the 2019 reporting year. And so then, earlier on in 2019 is when they released the specifications, and it did not include how to account for dental, because who knew? Who knew then what we've experienced now in 2020? So I will follow up on that one, Allison. Thank you for your question. And I will check with UDS to see if they will be expanding the criteria or the requirements. Okay, so the next question is, how can I add a provider to the staff section of the UDS report maintenance window? So for the provider that you see listed in the staff section, that list comes from the provider maintenance window. So any provider that have been added there will automatically list to the staff list that you see in the UDS report maintenance window. Okay, the next question is, how are the Medicare G visit codes reflected in Table 9D in the UDS dashboard? Okay, this is a great question. All right, so for Medicare billing, there's the way that Energy has been set up that I'm familiar with is when you when certain, I guess, visit codes are keyed. Let me just use a standard example of like a 99213. That's just an example. It may not even be for Medicare, but what ends up happening is that an alternate code, and it's one of the I guess they're called like payment codes, will automatically post. This is not a code that you actually have to post directly. If you have your Energy set up for this with an alternate list, it will automatically just post in the charge record. And then the way that the report works is that it will display the Medicare G code, but it will not use it in tallying up the total for total charges. It's just for visual. So that's how it would work. If you are seeing something different, Christine, please let me know, because Greenway has coded it or has designed Table 9D in the UDS dashboard to behave that way. It will still list the Medicare G payment code right alongside of the actual code that was built to Medicare. Okay. There's actually additional information about how this works for Table 9D in the UDS, the Greenway User's Guide for UDS. So it's probably a better explanation than I've given you now, but I will expand on this in the FAQ, so that way it should address your concerns. The next question has to do with, will Insights clinical dashboard be available with this update? Actually, the Greenway Insights is a totally separate system. What you will experience when we upgrade to PA 1215 is that the clinical dashboards that you might be accustomed to seeing now in Practice Analytics will no longer be there. It's going to be removed. And so Greenway actually has been planning on releasing Greenway Insights. Its initial release was supposed to be for December, but it's been delayed. So I think their new release date might be sometime in January. Let me get back to you on that one because I don't have the exact date. But once information about Greenway Insights, once the release is available, then we will definitely be sharing that information to our health centers. Okay. Question came in, have all of the updates to the PA dashboard been completed? I believe it's been announced to a global communication has gone out by Patrice Telek that the PA Practice Analytics 1215 upgrade has been scheduled. It's actually a staggered schedule, so not everyone is being upgraded at the same time. Some centers have already been upgraded starting this week, and more updates will occur throughout the rest of this month. So until, like, once you get your communication specific to your practice that PA will be upgraded, then you know, okay, that that the dashboard, UDS dashboard, is available for 2020 reporting. Now, if your center hasn't gone up yet, hasn't been upgraded yet to PA 1215, I highly encourage you to run any reports that you might want to compare against. And, specifically, you might want to, and I know HCN, like for me, since we will be looking at, what your numbers are pre and what your numbers are after the upgrade. We do run, a lot of data exports of your UDS numbers, especially with the clinical numbers, because we know that changes are going to be made on the clinical reports. But right now, I mean, most of the changes are with the clinical reports and not so much with the demographics. So, but it's still important that you can at least minimally export your UDS scorecard and maybe export some details like the UDS universe, just so that you at least have a copy of what patients were reflected before the upgrade. So that way you can make sure that nothing major has changed after the upgrade. Okay, so it's 3:07. We certainly still have time for asking for questions, for more questions. If anybody has any questions, please feel free to either raise your hand and I will unmute you, or you can unmute yourself if you wish to ask any live questions. Okay. Okay, well, that's great. If there are no other questions, then I will give you back 28 minutes, 22 minutes of your time. I wish to thank you for attending today's session. As soon as the session is over, you will receive a pop-up to complete a short survey. If you could spend just 2 minutes of your time just to complete that survey and provide your feedback, we will really appreciate it. It's important for us to know, how we're doing and how we can improve. Because we definitely want to give you, more trainings that are valuable and deserves your time. So I wish to thank you for attending today's session, and I would like to wish you a great long weekend as well. Have a great rest of your afternoon. Thank you, everyone.